As a result of hyperparathyroidism, blood and urine calcium levels increase, and the patient complains of excessive thirst, frequent urination, fatigue, weakness, loss of appetite, nausea, and vomiting. Because the urine is laden with lime salts, stones tend to form in the kidneys, and as lime is withdrawn to maintain high calcium levels of blood serum and urine, the bones soften or become brittle and are easily fractured, sometimes without any apparent injury. If hyperparathyroidism is due to overdoses of vitamin D or of milk and alkali, the therapeutic course is obvious. But if suspicion centers on the possible presence of parathyroid adenomas, surgical exploration may be required. And this week on Audio Digest Surgery, Volume 18, Number 23, Hyperparathyroidism Today, with 4 surgeons, John P. Delaney, B. Martin Black, Richard H. Egdahl, Edwin L. Kaplan, and 2 internists, Claude D. Arnaud and Richard P. Doe, discussing recent clinical applications of radioimmunoassay of plasma parathyroid hormone in diagnosing parathyroid disease, a simplistic approach to diagnosis that does not emphasize serum parathormone levels, advances in management, and the concept of normal calcemic hyperparathyroidism. Dr. Delaney, serving as program moderator, introduces the first speaker.
Dr. Claude Arnaud is going to talk about a topic of great current interest. We'll see what Dr. Arnaud has to say about that.
We have been very lucky in developing parathyroid hormone radioimmunoassay. A typical radioimmunoassay was constructed by adding increasing quantities of various hyperparathyroid sera to the immune system, and as the bound-to-free ratio decreases, classically, the hormone concentration increases, or as the hormone concentration increases, the bound-to-free ratio decreases. The assay is based on the inhibition of the immune reaction between I-131 labeled parathyroid hormone and antibody by adding stable parathyroid hormone. The stable parathyroid hormone here is in standard hyperparathyroid serum. The important point is that all of the sera that we were able to obtain from a variety of different clinical hyperparathyroid disorders, ranging from tertiary hyperparathyroidism to secondary hyperparathyroidism due to malabsorption to primary hyperparathyroidism due to adenomas, all seem to follow the same classical immune reaction. First of all, in hypoparathyroidism due to surgical removal of the thyroid gland, the assay does not measure any parathyroid hormone in the serum. Secondly, in normal patients, the assay seems to be able to measure the hormone in more than 95% of sera. Third, parathyroid hormone is generally increased in patients who have parathyroid adenomata. Now, it's interesting that there is an overlap in this particular assay between individuals who have proved parathyroid tumors and individuals who are normal. That might be the case. We have a group of suspected parathyroid tumors who also have relatively increased parathyroid hormone concentrations in their blood. However, none of them are unmeasurable. The concentration of parathyroid hormone in the blood of individuals who have hypocalcemia, normal renal function, but presumably do have parathyroid glands, is appropriately increased. And the concentration of parathyroid hormone in patients who have chronic renal failure is uniformly increased to anywhere from 3 to 300 times normal. Now, back to this overlap that we were talking about. The normal range for the serum calcium in our laboratories ranges between 8.9 milligrams percent and 10.2 milligrams percent. The normal range for the serum parathyroid hormone ranges in our laboratory from undetectable to approximately 40 to 50 microliter equivalents per ml. When we plot individuals with relatively mild hyperparathyroidism or a hyperparathyroidism associated with parathyroid hormone concentrations below 150 microliter equivalents, and those individuals who are hypocalcemic for causes other than chronic renal failure, there is a negative correlation or a negative regression between the serum parathyroid hormone concentration and the serum calcium concentration over the normal range, so that at low concentrations of calcium in the normal range, 8.9 or 9 milligrams percent, the serum parathyroid hormone concentration is appropriately increased, and at concentrations of calcium which are at the upper limits of normal in the range of 10 or 10.2, the serum concentration of PTH is low, or in the lower normal range, and in point of fact, the only undetectable values we find are those who have serum calciums in the very upper range of normal, 10, 10.1, or 10.2. In contrast, the individuals who have parathyroid adenomata fall along a positive regression line. That is, as the serum calcium concentration increases, the serum PTH concentration increases, which is exactly what one might expect in a situation in which the tumor is functioning autonomously. And if one looks at this overlap range that we were speaking about before, by discriminant function analysis, or for that matter, just by inspection, one can see that if one measures parathyroid hormone in the blood of an individual who has a serum calcium above the normal range, this individual probably has a parathyroid tumor. And there is a clear separation between the normal group and the hyperparathyroid group when one considers both the serum concentration of calcium and the serum concentration of parathyroid hormone. The PTH versus the serum calcium of a large numbers of parathyroid tumors. There is grossly a positive correlation between these two indices. However, there are clearly several subpopulations, individuals which have relatively high serum calcium concentrations, but relatively low, but yet abnormal parathyroid hormone concentrations, individuals with relatively high PTH concentrations, but with relatively low PTH concentrations. We have not yet defined these subpopulations in terms of the cause of this apparent discrepancy. One of the things that seems to have helped us, at least in predicting the size of the parathyroid tumor the surgeon might see when he opens up the neck, is the parathyroid hormone concentration. The higher the hormone concentration, the larger the tumor we expect to find. And in point of fact, if the PTH concentration is available prior to surgery, and it is very high, we ask our surgeons, or we'd like to ask our surgeons, to look for a tumor that's larger than 100 milligrams in size. The same kind of correlation exists between the serum calcium and the tumor weight. There are exceptions, of course. Now, one of the things that has been extremely disturbing in the differential diagnosis of hyperparathyroidism has been the presence in a hypercalcemic, hypophosphatemic group of a group of individuals, which are relatively frequently found, who actually have an ectopic tumor or cancer, non-parathyroid in origin, which apparently produces sufficient parathyroid hormone to produce these biologic effects, hypercalcemia and hypophosphatemia. We see this kind of situation in ectopic hyperparathyroidism, a group of individuals who number 18 had serum calcium concentrations of 13.2 milligrams percent and a serum phosphate concentration of 2.6 milligrams percent. And the comparable group of about 55 patients with hyperparathyroidism had comparable serum calciums and serum phosphates, although the serum calcium concentration in the ectopic producing group apparently was significantly higher. Yet, the serum parathyroid hormone concentration of individuals who had proved primary hyperparathyroidism was considerably higher than those individuals who had ectopic hyperparathyroidism, and in point of fact, there were a rather large number of individuals with the ectopic syndrome which actually had undetectable levels of parathyroid hormone. And if one plots the results of the serum calcium determination, serum parathyroid hormone concentrations of both the primary hyperparathyroids and the individuals who had ectopic hyperparathyroidism, there is a clear separation between this group of individuals who have ectopic and those individuals who have primary, except for 2 instances of renal carcinoma, which had perfectly appropriate increases in their serum parathyroid hormone concentrations for their serum calcium concentration. And this apparent difference in the ability of the antiserum to see the material, PTH-like material circulating in ectopic hyperparathyroidism has been very helpful to us in the clinic in trying to distinguish between the cancer hyperparathyroid patient and the individual who has primary hyperparathyroidism and requires neck surgery. Now, switching to something we all know about, and I'm sure we all have had experiences with, the multi-channel screening examination with the measurement of serum calcium, and it's suddenly coming up with an individual who's relatively asymptomatic who has hypercalcemia. Well, we started a routine health examination service at the Mayo Clinic. In the course of doing this, we measured the serum calcium consecutively in 1,630 patients. The series, I think, is about 2 or 3 times larger now. And the results are essentially the same. And we were able to detect hypercalcemia on the initial blood study in 96 or 5.9% of these patients. Now, this was confirmed in approximately the same number on 3 determinations, which is a rather high incidence of hypercalcemia, and in our experience probably is the highest yield from this multi-channel screening technique in terms of detecting an abnormality. Now, in 33 of these patients, the diagnosis of hyperparathyroidism was excluded. However, they were ill, in most instances, with cancer. The diagnosis was doubtful in some 35, and in point of fact, these individuals are being followed, but the problem really relates to the fact that they have high normal serum calciums and their PTHs are probably normal. Now, of this 96 patients, we have made a diagnosis of provisional hyperparathyroidism in 20 of these, and these are not being operated on primarily because they have fallen into the group that we have elected to follow for this disease, and that's another discussion. But they, as far as I'm concerned, have the disease. Their serum calcium is increased, and their serum parathyroid hormone concentration is increased. And we have proved the diagnosis in 4 of these individuals, and the average calcium is high, and the serum parathyroid hormone concentration is high. These individuals had primary hyperparathyroidism. So that at the minimum of this group of 1,634 of the patients had hyperparathyroidism, completely unsuspected. This is relatively severe disease, or 0.2% of the total. And we're fairly certain that this 1.2% exists as primary hyperparathyroidism, or a total of 1.4% out of 1,630. And we feel this probably approaches a public health problem if the incidence continues as is. Now, these individuals are not necessarily normal, as you all must agree, because no patient probably walks through the doors of a clinic without having some complaint. So we're not saying that this is the incidence in the general population. Now we'll go on to some of our work in the hemodialysis area. As you increase the dialysate concentration of calcium, you increase the net gain of calcium to the patient. And at the classical concentration of calcium that one uses in the bath, which would be 5 milligrams per 100 ml, the patient gets practically no calcium. And since these patients are in negative calcium balance and are losing large quantities of calcium from their gut, these chronic uremics are in negative calcium balance during the entire period of time that they're being dialyzed. What we have done is essentially attempt to restore their calcium homeostasis to as close to normal as we can possibly do by first lowering their serum phosphate concentrations to within the normal range with amphigel or aluminum hydroxide gels, and increase the dialysate calcium concentrations to somewhere in the range of 7 to 8 milligrams percent rather than 5. And we've been able to show that the PTH concentrations in their blood decrease progressively, and their plasma calciums increase into the normal range, so that their serum calcium and serum phosphates are perfectly normal after their phosphates are decreased. And then if we decrease the concentration of calcium in the dialysate to the 5 milligrams percent, which is used frequently throughout the country, the serum PTH increases very briskly over a period of 2 or 3 months, and the individual ultimately probably feels the effects of this increased PTH in the form of renal osteodystrophy and hyperparathyroid bone disease. The reversed experiment is done where the individual is started in a low dialysate bath. We decrease the phosphate concentration in their blood by amphigel, increase the dialysate calcium, and progressively decrease the parathyroid hormone concentration in their blood to normal. And we feel that this is a very effective way of treating these individuals. However, one of the serious problems we've found is to obtain good patient cooperation with respect to taking amphigel. They don't like it, doesn't taste well, and a great need is therefore created right now for a palatable amphigel or aluminum hydroxide gel or a phosphate binder, which we have not yet found. Finally, very brief comment about our experience with hyperparathyroidism post-renal transplant and what happens to the serum parathyroid hormone as a function of time after renal transplantations. There is a progressive, generally rather rapid decline in the parathyroid hormone concentration after transplantation. And the rate of this decline is generally related directly to the initial concentration of PTH prior to transplantation.
I think one of the more frustrating experiences a surgeon can go through is to operate on the neck of a patient with hypercalcemia and find slowly and with great effort 1, 2, 3, and finally 4 normal glands, and then open the carotid sheath and look behind the esophagus and remove as much of the thymus as he can get from the neck and probe down into the mediastinum, and finally, after a number of hours of frustrating work, give up and say, well, the diagnosis was wrong in the first place. Dr. Doe, who is our chief of the combined endocrine section of the university and the Veterans Hospital, is going to speak to us now about the diagnosis of hyperparathyroidism, or the differential diagnosis of hypercalcemia.
I'm going to present a simplistic approach to the diagnosis of hyperparathyroidism, one that does not emphasize serum parathormone levels, because as we talk about this, 90% of the people in this room cannot get serum parathormone levels measured. There are just a tiny handful of laboratories that do it, and those that do are so overloaded that it takes 3 to 6 months to get answers back ordinarily. And so I'll tell you about the approach we've used for the last 11 years that essentially revolves around establishing hypercalcemia that's persistent, going down a checklist of causes of hypercalcemia and eliminating the other causes, and then operating on the patient. And using this approach, we had one string of 24 consecutive patients without a false positive or false negative diagnosis. And I think our current series must be 30 in a row. So there's a good deal that can be done without parathormone assays, and as they become available, undoubtedly the batting average will improve further. Now, for many years, the reports from the Massachusetts General Hospital and the Mayo Clinic indicated that 3 to 5% of patients that were renal stone formers had hyperparathyroidism. And perhaps undefined bone disease, especially if it had cysts, was also an indication for getting a serum calcium level. And as time went on and the serum calcium measurement became better done, this indication was extended to perhaps, by some people at least, complicated peptic ulcer disease and later unexplained cerebral malfunction. And these patients could have anything from fatigue to semi-coma, especially in the more elderly patients. Family history is perhaps the highest yield indication for a serum calcium concentration. Now, there seem to be at least 3 kinds of families that have hyperparathyroidism. The first is the multiple endocrine adenoma syndrome. It occurs in families, occurs sequentially, frequently has a typical adenoma or 2 adenomas. As a capsule, has compressed normal parathyroid tissue around the rim and is cured by removal of 1 or 2 adenomas. Now, the second type of family are families that have just hyperparathyroidism, no other endocrine disorder at all. They tend to have peptic ulcer as a strong feature in the family, and as we operate on those patients, we get a picture of mixed chief cell, oxyphil cell hyperplasia. Some glands are larger than others, but that form is cured only by taking out 3.5 parathyroids. Now, we studied about 5 families so far. We find that of the patients in these families that have just hyperparathyroidism, the siblings are involved 75% of the time, an extremely high incidence. The third type of family is the Sippel syndrome family that has medullary carcinoma of the thyroid, pheochromocytoma, and parathyroid adenomas, and there we seem to be getting both adenomas and hyperplasia. Now, the screening reported in the Annals of Internal Medicine by Boostra and Jackson from Bluffton, Indiana, a somewhat perhaps less illustrious clinic than the Mayo Clinic, and perhaps without as much chance or risk of referral problems as the Mayo Clinic has. And their incidence of hyperparathyroidism in 26,000 consecutive patients screened, each one that came in the door got this test, was 0.12%. So the question is whether 0.12% or a 10-fold increase, as we heard from Dr. Arnaud, is the incidence. But there is an incidence of hyperparathyroidism that can be detected only by routine screening. 8 of 31 patients with hyperparathyroidism had either renal stones or complicated peptic ulcer disease. Another 7 had fatigue or irritability as a presenting symptom, something so nonspecific that it cannot be relied upon. 1 of the patients with multiple myeloma was unsuspected, and of the 17 patients with malignancy, 4 were unsuspected at the time the screening was done. Now, as we've treated these patients that are thought to be asymptomatic in families with hyperparathyroidism, we find that in retrospect, after going over the history very carefully, that the patients do really have symptoms. And these symptoms revolve around irritability and fatigue. And as then the family comes in and we talk about this with relatives, the husband will say, she's doing more than she's ever done, she's less irritable, it's a great thing that you've done. So perhaps not all these patients really are asymptomatic. Perhaps they've had hypercalcemia so long that fatigue and irritability are just part of their makeup as far as they're concerned. Now, hypercalcemia can be caused by hyperparathyroidism, but as we said, malignancy, both metastatic bone tumor and ectopic PTH production can cause this. Multiple myeloma can cause hypercalcemia, both because of bone involvement and because the abnormal protein in the blood can bind calcium and decrease the ionizable calcium fraction. Vitamin D intoxication can cause hypercalcemia, and unfortunately this can last, once the vitamin D is stopped, it can last as long as 9 months, or it may disappear very quickly after stopping vitamin D. And this history has been very hard to obtain, because ask a patient if he's taking pills, tablets, medications, and so on. He says no, but on one instance at least we found that the patient was taking Vern-Gagne pep pills #2, which have 25,000 units of vitamin D in, and are sold over the counter, and those weren't tablets or pills as far as he was concerned. The milk alkali syndrome, classically as described by Burnett, has a high BUN and hypercalcemia and low urinary calcium, but there are various early forms of this that really do not have all those features, and because of their existence, we've chosen to make sure that the patients that we're working up stop drinking milk completely during the period before they come in the hospital, and we try to get the history of ingestion of calcium carbonate, especially containing medications Tums, Titrolac, and other absorbable alkali, and get those stopped for some time. Sarcoid can cause hypercalcemia because of increased absorption. Metal intoxication is another cause that's rare, berilliosis, lead poisoning, manganese poisoning. Hyperthyroidism is a cause of hypercalcemia. Again, the history and physical tends to rule out most of these problems. Hypothyroidism is a little recognized cause of hypercalcemia. Most of the reports are in children who are ingesting 4 to 6 glasses of milk or the equivalent a day and who are also hypothyroid. And once the milk ingestion is stopped, the patient that's hypothyroid clears calcium slowly from the bloodstream, and this is the apparent cause of their hypercalcemia. Adrenal insufficiency can cause hypercalcemia, Addison's disease, ACTH deficiency, steroid withdrawal, hypopituitarism. Again, the history and physical tends to rule out this cause. Paget's disease or osteoporosis, both with bed rest, can cause hypercalcemia. Thiazide therapy, through an effect apparently on the renal tubule, can cause hypercalcemia. This is ordinarily modest in amount and lasts only 5 to 10 days. Tertiary hyperparathyroidism, of course, is one cause that must be thought of in someone with renal failure. And the transplant patients and dialyzed patients, of course, is no problem really most of the time. And then just to be complete in terms of finding out the etiology of the hypercalcemia, idiopathic hypercalcemia of infancy, something I don't see too much of, and which is present frequently in the newborn. And half of those mothers are taking huge doses of vitamin D during the pregnancy. And so if we have a patient that one way or another is found to have hypercalcemia, and if we can show that 3 times out of 4 or 4 times out of 6 the serum calcium is elevated, we go through this checklist. Most of those causes are ruled out by the history and physical examination. Now, we haven't emphasized serum phosphorus for screening. It costs almost as much as the serum calcium, except perhaps on the automated methods. 40% of the time it's normal in hyperparathyroidism. In idiopathic hypercalciuria, 25% of the time it's low or low normal. So it really isn't very helpful in screening, and we can get by just with the serum calcium. But once we have persistent hypercalcemia, it's sometimes useful, and alkaline phosphatase is useful, both because of bone disease and possible Paget's disease. Chest X-ray is helpful to rule out sarcoid or lung tumor, bronchogenic carcinoma. Routine bone films are done, including the skull, hands, spine, and metastatic bone survey. Serum electrophoresis, done routinely. Creatinine clearance, done routinely. If we decide not to treat the patient, the creatinine clearance probably should be followed for possible progressive renal disease, an indication for treatment, an IVP once myeloma has been excluded, so that the paradoxical reaction to IVP dye does not occur, and hopefully serum parathormone radioimmunoassay, which I'm sure will be a powerful adjunct in this differential diagnosis once it's more routinely available. Now, if through the history and physical these things seem indicated, urinary electrophoresis or bone marrow for multiple myeloma, thyroid disease, T4 bicolumn or kinemametry, ACTH infusion test or a metapyrone test if that seems indicated, fractionation of the alkaline phosphatase to identify hepatic versus bony origin of that if it's elevated, if the liver is enlarged or abnormal lymph nodes are present, biopsy of those tissues. Now, I suppose this is controversial for me to say that these things aren't useful, but I really think they're not. The selenium scan shows parathyroid adenomas, but it shows those adenomas that are large enough to be found easily anyway. There really are very few, if any, patients that have benefited from a selenium scan. Cortisol suppression test has been confusing because serum calcium levels tend to fluctuate with hospitalized patients, and 5% of parathyroid adenoma patients suppress normally. So we'd have to give up that group of patients. 24-hour urinary calcium on a low calcium diet has been a standby, but if the patient has renal impairment, the failing kidney will retain calcium, or he may be in a position of having osteomalacia from malabsorption and have misleadingly normal urinary calcium concentrations. Tubular reabsorption of phosphate on a high phosphate diet has added very little. The phosphate deprivation test to provoke hypercalcemia has added little, as has the calcium infusion test. Now, I might expand on that and say that there are reports from Barter and from the St. Louis group of normal calcemic hyperparathyroidism. I haven't talked about that because I think it's in such an early stage of development that it's hard to say much solid about it. But Dr. Barter uses a calcium infusion test and defines the change in urinary phosphorus concentration in those patients. Perhaps that's where this test will be useful, or measuring parathormone levels with calcium infusion. So that may come back as a useful test. The St. Louis group studying idiopathic hypercalciuria in stone farmers uses percent tubular reabsorption as indication for surgery. But those patients so frequently have normal-looking, normal-sized parathyroid glands. Their histology to me is confusing, and I think we should keep an open mind as to whether we should start going after those patients or not.
The conclusion of Dr. Doe's simplistic approach to diagnosis signals the end of Side A of this program, Doctor. Side B, with discussions of advances in management, normal calcemic hyperparathyroidism, and a question and answer session, can be heard by just flipping over your recorder's cassette or 2 reels. Continuing a program on hyperparathyroidism today, this is Audio Digest Surgery, Volume 18, Number 23. Once again, our program moderator, John P. Delaney.
Next speaker is Professor and Chairman of the Department at Boston University. Dr. Egdahl is our next speaker, and will talk on advances in the management of hyperparathyroidism.
To discuss the diagnosis a little bit, as has been mentioned already, the classical features, skeletal changes and kidney stones, we're all well aware of. More recently, pancreatitis has been described, and I think there's some question now in the minds of many of us as to whether peptic ulcer is in higher incidence in patients with parathyroid disease than in the general population, with the exception of the ZE syndrome. I think the most important thing is, as has been mentioned by Dr. Dole, personality changes have come to be a prominent feature in the patients that are now referred in for parathyroid surgery. I'd say a third of the patients that I've operated in the last 2 years have come in with mood changes, transient psychoses, etc. We also have noticed a high incidence of hypertension in our patients, in several of whom the pressure came to normal after removal of the adenoma. We're currently working on the relationship between this, the magnesium ion, and hyperaldosteronism. Dr. Melby seems to think there may be some relationship. At least I think you should be aware of the fact that our scan of the patient categories that may have primary parathyroid disease are not now exclusively located with patients with kidney stones and with bone disease. We've got to now have a more broad outlook on it. I agree with Dr. Doe that the selenium scan is probably relatively valueless. I think that perhaps Dr. Poshnitz at Washington University of St. Louis is the only person still working on refining this method so that it can be used critically diagnostically. At least in most places I know this is not used as a diagnostic method. There's a lot of surgical interest in the use of toluidine blue, and for those of you that read the various surgical journals, almost every other month there's a paper saying that intravenous toluidine blue is injected and it shows up the glands. The criticisms of this method are twofold. Firstly, for the experienced parathyroid surgeon, the problem is not seeing the glands that are in the operative field. It's finding the glands that are in the mediastinum or that are behind the esophagus or in the carotid sheaths, which you can't see, even if they're stained blue. And the problem for those of us that work in this area is not finding the glands that are in the usual locations. The other thing is that to get the glands anywhere near as blue as that, you have to give a dose of intravenous toluidine blue that gives you cardiac arrhythmias that at least make most of us sort of nervous. And the borderline between a really toxic range and a range that won't even show the glands in blue is relatively narrow. Some of the techniques that are being devised to hook an isotope up with this dye are perhaps interesting, but I think we again will have the problem that if you're going to get enough concentration of an isotope in the gland to stay there long enough, one may have some difficulties in terms of tetany in the remaining normal glands. So I don't think this is a particularly fruitful technique for the future of parathyroid surgery, and I certainly don't think it's clinically applicable for those of us doing this surgery at the present time for the reasons I mentioned. The value of the cortisone suppression test. I agree with Dr. Doe on almost everything he said except that. I think there are cases where the cortisol suppression test can save you an unnecessary operation. Many of you will recall Dr. Cope's delightful paper a few years ago called The Vicissitudes of Parathyroid Surgery, where they described over 60 cases, around 60 cases that they had at the Massachusetts General Hospital that were incorrectly diagnosed and operated on. And this is a beautiful paper to read because they've had a large experience there, and these were the cases that had been misdiagnosed. You can do a liver biopsy, of which 50% will be positive for sarcoid. You can do a Cavine test if you want, if you can get the antigen. But by far the simplest thing, and almost 100% of patients with sarcoid will get normal calciums within 3 or 4 days. On the other hand, as Dr. Doe has said, a small percent, 2 or 3 or 4 or 5% will get normal calcemia with hyperparathyroidism. Always look carefully at the chest x-rays, always take a history and go over the patient, and if he's sicker than he should be for just having had a few kidney stones, do the cortisol suppression test. A few patients with tremendous avidity of the bones for calcium may develop a subliminal tetany in the post-op period for several weeks while they recalcify their bones. The moral, give a lot of calcium in the post-op period to patients who have had an adenoma removed if they have severe bone disease. Another thing, the pathologist is superb to work with, but that sometimes he can't help you and you feel mighty lonesome. You can't always rely on the pathologist at surgery to bail you out if you've got one of these small adenomas. You have to go ahead and take it out and wait. It now is not possible, I don't think, for the pathologist, even if he gets a frozen section that's just beautiful with a rim of normal gland and with a compressed sheet of cells, to say this is an adenoma, quit. You've got to always look at all 4 or 5 glands. You never only do one side. You never fail to examine the thymus, because you may have a 5th gland with a 2nd enlargement, whether it's a 2 hyperplastic or 2 adenomatous glands, again, I don't know. But at least frozen section doesn't prove that we've got an adenoma, which it used to in our minds a few years ago. You can have 2 normal glands and 2 big adenomas. You shouldn't split the sternum the first time around. You can have a totally intrathyroid parathyroid adenoma. We've had 3 such cases in the last 3 years. We have had about 1 a year. I think this is probably pretty good evidence that you oughtn't to go ahead the first time around and split the sternum, because it can be in the thyroid even if the thyroid seems relatively translucent. Now, switching gears, you can get cases of hyperparathyroidism in transplant patients or in patients in dialysis. A post-transplant patient with relatively normal renal function developed this strange syndrome that Shaul Masri at the Cedars of Lebanon described in the last part of last year in the Green Journal, of peripheral vascular necrosis, vascular calcification, and of a rapidly reversible syndrome due to perhaps calciphylaxis. Certainly no such syndrome occurs just because of a level of calcium of 11, which is what this patient had. This man progressed on to necrosis of his extremities in a matter of about 6 weeks or so. He started with perfectly normal blood vessels, and within a matter of 2.5 months, his arteries in his hands and his legs, not his major central arteries, were totally calcified. At surgery in the neck, when we took out the parathyroids, we took out a piece of these arteries, and our vascular and metabolic people are studying these, this being what Bob Good would call an experiment of nature, because within a matter of a few months, this vascular calcification was regressing. The skin lesions had totally healed, and we quite obviously had had an example of what Dr. Selye calls calciphylaxis, I would think, perhaps sensitized by the cortisone that the patient received in the post-transplant period. It's a fascinating type of situation that occurs and may well give us some insight as to, in a sort of a rapidly compressed period, the etiology of atherosclerosis itself. The immunoassay, Dr. Arnaud has done so much at the clinic to really make this assay practical to solve some of the pressing clinical problems that exist. You can separate the normal patients from the patients with proven adenomas or suspected adenomas, with the patients with either surgically created or primary hypoparathyroidism in the unmeasurable range. Now this has held up pretty well. Dr. Reese's assay has some problems. It's slower than some of them and it's sort of tricky, but it is pretty accurate in separating the normals from the abnormals, at least as accurate as any that I know, which has been its main strength. And I think this, of course, will be a prime feature when we get to wondering whether we operate on patients that are relatively asymptomatic, that have clear-cut hypercalcemia, which I'll say a word about in a minute. Now, the applications of the immunoassay to us as surgeons, I think, are clear-cut. And I think this is one of the really exciting advances in the last few months, actually, or 6 months to a year. What we found a few years ago is that when we were maneuvering in the neck to get blood samples in patients, and we were measuring peripheral blood parathyroid hormone as we were taking out the adenoma, that we invariably got a marked increase in the peripheral blood concentration of parathyroid hormone as we manipulated. So the idea came to us, perhaps we could help the surgeon by, in the preoperative period, doing some maneuvers that would, by measuring the peripheral blood hormone concentration, tell us which side the tumor's on. This led to what we call the parathyroid squeeze test. And as I have learned from discussing this with various endocrinologists and surgeons around the country, the efficacy of the squeeze depends largely upon the vigorousness of the massager. And there are some places where this has not worked at all. All I can say is that this is the data that Eric Reese and I got on our first batch of patients. In none of the cases of the normal control patients did we get any significant change from the baseline level of parathyroid hormone concentration. On the other hand, in the patients with primary hyperparathyroidism, all of whom had elevated initial concentrations of parathyroid hormone, when, for example, we massaged the left side of the neck, we got no change. When we massaged the right side of the neck, we got a very significant change in parathyroid hormone concentration, and indeed the adenoma was on the right side. The same thing is true with one on the left side. Now, we massaged the right and the left side of the neck, and the first conclusion would be we had a bad massager. Well, since it was the same massager that had done the other ones, there is another conclusion, and that is that the adenoma or the hyperplastic glands aren't in the neck. And indeed, that is a mediastinal adenoma. If it goes up on both sides, or whatever you want to call it, I'm sort of totally confused now. I don't know what terms to use, but at least it was big glands, or at least it was glands that are hyperfunctional on both sides. They're hyperplasia. And this helped tell us because it meant we had to go after both sides. Perhaps the best use of all, though, for us is going to be the catheterization of the veins. The patient referred me, been operated at 2 major medical centers with continued hypercalcemia. A venous catheterization study shows concentrations 5, 2, 6, 7. The highest level was right in the nominate. The tumor that I ultimately found in the mediastinum underneath the clavicle. Now, in this instance, having positive parathyroid hormone concentrations helped me know to go underneath the sternum. This helped me preserve the man's recurrent laryngeal nerves. It directed me into the mediastinum, and I was all set, if I hadn't found the thing within 20 minutes or so after I'd gotten good exposure, to split the sternum. Now, the most exciting advance, I think, in the whole field is within the last few months. At the Mass General, the radiologists there have been catheterizing the very small veins. And unlike this differential, which may be twofold, they've found concentration differentials of between 20 and 200 times by getting into the very small veins, draining the different portions of the thyroid, and then by analyzing the small amount of blood obtained for parathyroid hormone concentration. I, at least, will not operate on a patient that's been operated on elsewhere that I've done myself with a diagnosis of primary hyperparathyroidism again, without having the benefit of this differential venous catheterization and analysis for parathyroid hormone concentration, because I think it'll save me hours, and it'll save me some recurrent laryngeal nerves, and it'll certainly be better for the patient. Now, just to wrap this up, since we've all had a lot of experience now with renal azotemic osteodystrophy and subtotal parathyroidectomy for it, and we have had more experience with the treatment of tetany, the treatment of hypoparathyroidism, either in the immediate postoperative period or on a chronic basis, has become relatively routine. The intravenous calcium gluconate is always available in special care in the wards. Oral calcium and vitamin D works pretty well over the chronic haul. I found that if you have a patient that you have removed 3.5 glands, or a very large adenoma or something or other, and you've got some fall in calcium, and it's drifting down from 8 to 7 to maybe 6 milligrams percent, and there's sort of a little bit of incipient tetany or a moderate schwastek, and you've got the patient in a special care unit, I would rather follow that patient for a day or two, letting them get a little bit mild tetany and then coming out of it, than to give them the calcium for a couple of days and then have them just fine, having received calcium for 2 or 3 days, and then send them down to the ward. because I think that they sort of have to go through a period where the normal glands get revved up and come back and work. You know, of course, if they go into flagrant tetany, you have to give the calcium or if they get sick. But if they just got a borderline spastic, the best place to follow them is their special care and have them there for a day or so, and then they come back out of it, you send them down to the ward, and you don't worry. And I think this is true of a fair percentage of patients. This is one we can really argue about. There's two schools of thought that if you're going to operate for secondary hyperparathyroidism in the chronic stabilized renal patient, should you take out all 4 glands or 3.5? We've had 2 cases where we've taken out 3.5 glands. It hasn't budged the disease. We've had to go back in, and one patient, because of renal disease that then progressed, gave us some trouble. We feel that because of this principle of the treatment of hypoparathyroidism, that we don't now have to worry too much and that we can take out all 4 glands, or at least 3 other groups of workers do this. And finally, to focus on asymptomatic hypercalcemia, the proper treatment isn't clear. It's quite clear, though, that patients with kidney stones may have long asymptomatic intervals. Boy Freeman at Henry Ford Hospital has shown that. They've followed patients for 30 years with a kidney stone and hypercalcemia that have been perfectly normal, and then they've had another kidney stone, had a small adenoma removed. Unlike bone disease, where the tumors grow, the process is relentless. They get flagrant bone disease often. The kidney-type patients have stones, and they may have adenomas that stay dormant for many years. The real question is, at what level in a totally asymptomatic patient, and this is a patient now that isn't depressed, not jumpy or nervous or what have you, but it was a perfectly normal patient, when do you operate? I put in a level there that almost everybody will agree on. That obviously is ridiculous, 12 milligrams per cent. It depends upon what your level is, but if the patient's 11.5, most people would agree. At 11, perhaps most people in this room would agree. When you get down to 10.8 and 10.7, which is just above the normal limit for some laboratories with quality control, you get a real argument. I have a patient next Thursday I'm doing who is a gymnast. She's in perfect shape. She had the misfortune or the fortune to go to a multiphasic screening place. Her calcium's coming back 11.4. Dr. Melby and I, of course, went over the literature and went over our consciences, and she just looked us in the eye and she said, now, do I need to have my neck explored? I'm in perfect shape. I'm not depressed. I've read up on these articles. She said, do you gentlemen know what the answer is? And we said, well, we're not sure, but your calcium's creeping up. Well, we decided to operate on her. I'd say that's the borderline case. What about if it's 11 milligrams and she's really totally asymptomatic? The answer, gentlemen, is that we don't know. At the moment, to me at least, this is one of the really big things we have to settle. Perhaps the parathyroid hormone, if it's consistently elevated, will help us decide which cases to operate on.
Final speaker, Dr. Ed Kaplan. His topic is a controversial one and a difficult one. It has to do with normocalcemic hyperparathyroidism.
Hypercalcemia has long been considered to be the best index of primary hyperparathyroidism, perhaps the sine qua non. However, if one reviews the literature, many patients with proved parathyroid abnormalities have 1 or more serum calcium determinations which are normal. In a few individuals, the serum calcium was never elevated. Since they have no obvious reason to have secondary hyperparathyroidism, the concept of normocalcemic hyperparathyroidism has evolved. Actually, what is meant by the authors who describe this is normocalcemic primary hyperparathyroidism. Of 380 patients with proved primary hyperparathyroidism reviewed from the Mayo Clinic, Keating noted that at least 1 serum calcium was normal in 25 patients. This clearly demonstrates the need for multiple serum calcium determinations before ruling out primary hyperparathyroidism. However, it also demonstrates the rarity of the mean calcium being normal in these patients. In 1965, Barter and his group reported 14 patients with urinary tract pathology or with increased calcium in the urine who did not respond normally to a calcium infusion or to cortisone tests. Most or all serum calcium determinations were normal in each of these patients. At operation, 8 of the patients had parathyroid abnormalities, of which 5 were chief cell hyperplasia, while 6 others had normal parathyroid glands at operation. More recently, 3 other patients with borderline or normal serum calcium concentrations were described from the same institution. 2 were found to have small adenomas, and the patient was found to have chief cell hyperplasia. Throughout the literature, there are other instances of the same type of phenomenon. Most patients have hypercalciuria or a complication such as nephrocalcinosis or renal stones. Only 2 patients with normal serum calciums, parathyroid abnormalities, and osteoitis fibrosa, that is bone disease, have been described. Barter and associates proposed that the hypercalciuria and renal complications result from the parathyroid abnormalities, despite the normal or borderline serum calcium concentrations. If so, they feel that the treatment of choice is parathyroidectomy. So this is the problem. Why total calcium may be normal in some patients. One source of error which may lead to difficulty is the well-recognized fact that high standards of precision and accuracy in the determination of serum calcium are difficult to obtain in many hospital central laboratories. The normal range for calcium should constantly be re-standardized and the upper limits of normal carefully defined for the particular method used in that laboratory. Then the definition of hypercalcemia for that laboratory can be more precise. Keating and associates, for example, demonstrated that the normal values for calcium may be age and sex dependent. Young women have lower normal serum calcium concentrations than men of the same age. The normal values at the Mayo Clinic for men start out around 10.5, and women from the same institution have an upper limit of normal of about 10 to 10.1. Another source of error in measurement of total calcium is the serum protein. About 40% of serum calcium is bound to the protein as calcium proteinate. This represents chelated calcium, and I'd like to point out that about 40 to 45% is in the ionized form. The total calcium has been shown to be directly dependent upon the protein concentration of the serum. As the protein concentration, especially albumin, is raised, calcium proteinate also is raised, and the total calcium can also be shown to be raised. Therefore, if one has a low serum protein, the total calcium may be low on that basis. Perhaps we are measuring the wrong parameter when we measure total calcium. It has long been recognized that the ionized calcium in the serum is the fraction which is physiologically active. This is not influenced by the protein concentration. Furthermore, the range of normal is much narrower for ionized calcium than for total calcium. The new aids in the diagnosis of hyperparathyroidism. In the last few years, the Orion company has produced a closed system calcium ion electrode which has made the measurement of calcium ion dependable and relatively simple in many laboratories. 2 electrodes, a flow-through system, and a millivolt meter. The radioimmunoassay for parathyroid hormone is the most powerful tool that we have in studying calcium metabolism. The assay of Dr. Reese is able to differentiate normal individuals from those with hyperparathyroidism. When coupled with a calcium infusion, it may preoperatively differentiate hyperplasia from adenoma with great accuracy. 2 problems remain unsettled. First of all, are serum calcium elevations cyclical in some patients with hyperparathyroidism, and is this due to variations in parathyroid hormone secretion? Unfortunately, I don't have the answer, but this is a very important point. Secondly, what proportion of normocalcemic hyperparathyroid patients have secondary rather than primary hyperparathyroidism? We are just beginning to appreciate how sensitive is the regulatory control of parathyroid hormone secretion. In a study in which I participated with Dr. Reese, 1 gram of phosphorus was given orally to human volunteers. This resulted in a small rise in serum phosphorus and a small fall in both ionized calcium and total calcium. A change of 0.4 of a milligram% was sufficient to result in a 100% elevation in parathyroid hormone concentration. It's important to note that the serum calcium remained in the so-called normal range. There was only a difference of 0.4 of a milligram% in these values. Yet this stimulation is secondary to lowered calcium or secondary hyperparathyroidism. Another example is the chief cell hyperplasia associated with medullary carcinoma of the thyroid gland due to calcitonin secretion. Almost all of these patients have normal serum calcium concentrations. Again, this is secondary hyperparathyroidism. Undoubtedly, there are many other physiologic substances or metabolic derangements unknown at present which stimulate parathyroid hormone secretion. Coe, Canterbury, and Reese recently studied a group of patients with idiopathic hypercalciuria, all of whom had normal serum calciums and normal renal function. They all had hypercalciuria. However, some of them had hyperparathyroidism, elevated parathyroid hormone secretion, whereas others were euparathyroid. Treatment with thiazides in the patients who had elevated parathyroid hormone secretion uniformly resulted in a decrease in the parathyroid hormone concentration, a not too much consistent change in the serum calcium. However, there was a fall in urinary calcium in all except one of these patients. Therefore, it may be postulated that when parathyroid abnormalities occurred in these patients, they were due to the loss of calcium in the urine per se. That is a form of secondary hyperparathyroidism, and therefore not primary hyperparathyroidism at all. If so, this group may be treated better by means other than parathyroidectomy.
The questions have been picked up, and I think Dr. Black has the questions.
I would like to answer the first question that comes up. Do you explore the neck of patients with parathyroid adenomas when the only finding is an elevated serum calcium? The answer to that, broadly speaking, in the past has been yes, and we're not at all sure that that's the proper answer for the future. In the May issue of the American Journal of Medicine is the complete report of a symposium held in Rochester, Minnesota, in honor of the late Dr. F.R. Keating, Jr. This question is looked into at considerable depth, as is practically all aspects of hyperparathyroidism as known today. The second question I have, Dr. Doe, again, we're still on diagnosis here. What is the explanation of hypercalcemia and sarcoidosis?
Well, it's been shown that radioactive calcium, when given to someone with sarcoidosis, is absorbed in increased amounts. And presumably this is the answer, because if steroids are given, that increased absorption is brought back to normal, and the hypercalcemia ordinarily returns to normal.
You mentioned that in hyperparathyroidism, or did you? Someone mentioned hyperparathyroidism. Calciums are also suppressed by cortisol. Rarely.
Yes, about 3 to 5%.
3 to 5%, yes. So it's not an absolute test.
Right.
Dr. Doe, would you like to discuss hypercalcemic crisis?
Well, hypercalcemic crisis, I think, in terms of hyperparathyroidism, is quite unusual, and we get most of our experience with that in terms of cancer, with either ectopic parathormone production or with involvement of the bones. Our line one of defense is hydrate, ambulate, and steroidate, if you will. Give adrenal steroids, and if that doesn't work within a day or two, or if the level is above 15, we go right to 0.1 molar phosphate infusion, 500 cc's over 8 hours. Should bring the calcium down to a safe range.
Have you ever seen hyperparathyroidism with high calcium, serum calcium meaning, but normal urine calcium?
That's typical when the kidneys are involved, and especially if the GFR is decreased enough so there's malabsorption of calcium. Then you can have hypercalcemia, elevated BUN ordinarily, normal or low urinary calcium, prove hyperparathyroidism at surgery.
And this is what led to the virtual abandonment of the so-called OB test as a clinical test for hyperparathyroidism, where the patient was put on a low calcium diet, and then you measured the calcium in the urine. We were measuring kidneys rather than parathyroid. In patients with normal calcemic hyperparathyroidism, is the PTH when measured low or even normal? Dr. Kaplan, you must have had some experience in this area.
Well, I think this whole subject has to be studied further. I don't know, other than the data in which people with hypercalciuria, some of whom had hyperparathyroidism and some did not, and it did not seem to relate to the total amount of urinary calcium. Other than that, I have no other data on this.
I'd like to expand on this a little. This is one of the most important areas in clinical parathyroidology today. What do you do with the patient that's got a calcium of the upper limit of normal or the very slightest elevation of serum calcium, shall we say? What do you do about him? Whether it's normal calcemic or not, I think is a quibble. The fact is we're having difficulty recognizing minimal hyperparathyroidism. There are stone formers, indeed, who have minimal hyperparathyroidism and who will be benefited immeasurably by taking care of their disease. By the same token, I'm not at all sure that producing tetany in a patient who has normal parathyroid glands is going to help a bit. Dr. Kaplan.
One point I was trying to make in my discussion was that if you take the group of hypercalciurics in general, people have had very satisfactory benefit from the use of oral phosphate, for example, or using thiazides and diminishing the amount of urinary calcium, and that, for example, oral phosphates have been shown to lower the serum calcium as well. I'm looking forward with great anticipation to the results of the Mayo Clinic study where this very topic is being pursued.
Dr. Regdahl, you've had a vast experience with
Well,
PTH
I just
assays.
think you have to say that we're all awaiting the results of this study. I know of no one like it. The clinic one, it's got to go 5 years. Claude Arnaud's paper was just published in the Green Journal, has been stated, and it isn't definitive yet because we don't have the answers, such as in a patient with a borderline high calcium that's totally asymptomatic. Even if you had the parathyroid hormone levels that were elevated, maybe our instincts tell us that that might be some way to separate these patients from the ones that without elevated levels that might not need surgery at the time. But that's sort of guessing what's going to happen, and the only way we really be able to decide this, no matter what we all feel now, is when this study is run out, and indeed when a new study started that has correlation with all of the features that are so essential. We all have opinions.
Thank you, gentlemen. And our thanks, too, to the University of Minnesota Nolte Center for Continuing Education for cooperation in disseminating this material. Audio Digest Surgery is produced and copyrighted twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.